Thank you for joining us today, Dr. Abodeely.
Thank you for having me, Lynn Marie.
Am I pronouncing that right? I wanted to make sure.
Yes, Abodeely,
Okay,
correct.
excellent, excellent. Everybody's like, why didn't she ask that before she started recording? Last minute thought. Anyway, I found you because you had been a keynote speaker at a cannabis medicine conference, I believe, and I was just Googling to the ends of the internet to find a doctor who could talk to us about working with patients using cannabis and most specifically THC, because we did an episode on CBD and all of its benefits, and now we're going to move on to THC. So, if you could tell us just a little bit, because you didn't start off, in medical school doing a cannabis residency, because that's not a thing. If you could tell us what your training is in and what you started doing prior to when you started incorporating cannabis.
Sure. So I'm a board certified general surgeon, but I'm also board certified in colorectal surgery. So one of the biggest populations of patients who benefited from cannabis-based therapy have been cancer patients as well as inflammatory bowel disease patients. Those with suffering from Crohn's or ulcerative colitis. And one of my biggest patient populations are patients who have cancer. I'm a surgical oncologist, so I do a lot of the surgical oncology work, but I also deal with all the surgical problems that patients with inflammatory bowel disease suffer from. And at the same time, I also do a lot of the medical management. And as you may be aware, a lot of the medications and treatment options for patients with inflammatory bowel disease is not optimal. It's not ideal. A lot of these medications are significant side effects associated with the medications we use for inflammatory bowel disease. They suppress your immune system and can lead to all sorts of other potential infections. And so I was treating patients with our conventional pharmaceuticals, and then what started happening is I started to get patients who were admitting to me that, I'm not actually using the medications you prescribed me. I've been using marijuana. And I said, well, okay. And this started happening about 6 to 7 years ago. And so what I realized is that patients were actually really benefiting from it. Here they were, coming to me to receive care, and my care was providing them with suboptimal outcomes, and where they were experiencing great benefits from cannabis. So I knew there was something to it. So I spent years, and still to this day, I spend countless hours reviewing all the literature, and I did that very aggressively in the beginning so I could provide answers for my patients of, well, why is cannabis working when some of these other medications for my pain from my cancer, my pain or my symptoms from my inflammatory bowel disease, how come those medications aren't working but cannabis is? So I really needed to be able to provide them some information. And then New York State went legal from a medicinal standpoint in the beginning of 2016. So it's something that I knew was real, and so I decided to go through all the training so I could start certifying patients for medical cannabis. And but then I had to really spend a significant amount of time educating other doctors because I needed to get their buy-in as well. I knew that we knew that there was benefit. I knew there was benefit, but how was I going to relay that to my colleagues so they didn't think I was just out pushing marijuana for the recreational effects of it? So I've spent a great deal amount of time, scouring over the literature, and I've written a book on the topic, and so that's kind of where I've come today, and now I spend a great deal of time treating patients with a variety of conditions, with medical cannabis, and it's been a really eye-opening experience to see the benefits that this plant has.
That's very cool. And before we go further into those conditions, for the docs who are listening, in New York State, there was a training you had to go through before you could prescribe or before you could recommend. How did it work in that case? Because I know it's different state
Correct.
to state.
Yeah, yeah. New York State specifically, there is an online training course that you have to take. I forget how long it takes. Probably took me about a week or so, to get through. It's very basic, but it's enough to get people started, who are interested in certifying patients for medical cannabis.
And once you would certify a patient, and we'll get to the conditions, like I said, in a second, would you tell them a specific dose or What kind of guidance would you give them after certifying them?
Well, so the certification process, of course, the first thing we do is we go through their disease, their specific disease of what they're trying to to make sure that they're actually a candidate for medical cannabis, and which again in New York State is the only way you can get THC is you have to have a qualifying condition. And one first thing I always talk to them about is, well, what are the expectations? What are you trying to accomplish? Because everybody has different goals with this. Some people, they want it just to improve their quality of life. Some people want it to affect their disease progression, and some people want just their symptoms, treated. So that's the first thing I try to figure out from patient is really what are the expectations, and being clear on these expectations. And then following that, then we start talking about routes of administration, because the routes of administration have very different effects on an individual. And then I start getting into dosing with them. So that's kind of the last step in this is, that's kind of how I typically, interview patients and try to figure out an optimal regimen for them.
Okay. So let's get into the conditions that you have found cannabis has been really beneficial for your patients.
Well, certainly we can first start talking about cancer. Okay, now cancer is one of these things where there's several different reasons patients seek medical cannabis for cancer. One is, some certain cancers can be painful. And we know that, one of the biggest benefits that medical cannabis has is in combating pain. So, for patients who are suffering from either pain as a direct result of their cancer, but then a lot of patients develop neuropathies from their chemotherapy treatments, which we have great data on, knowing the utility this has for chemotherapy-induced neuropathies. So that's one of the reasons people with cancer would seek medical cannabis treatment. The other is whether they're having significant anorexia, loss of weight, which can be from the cancer itself, but can also be from the treatment regimens. The other reasons people use it for is to decrease opioid consumption. When patients, even if they're terminal and they're on multiple opioids, what that does to patients is it really makes them very tired, not interactive with their family, and at the last whether it be few days, few weeks, few months of their life, we've seen tremendous satisfaction, not from the patients but also from the family members saying, I can actually engage in a conversation with my loved one in their last days of their life, as opposed to just seeing them completely narcotized on a whole bunch of opioids. And I've witnessed that. I've walked into patients' rooms where they're actually having, although they're maybe in hospice care, but to see them actually enjoying a meal together and to see them engaging with each other and not being completely completely out of their mind and tired on all these opioids. That is another reason why people use it. The effects that it has, although we can't say this, in New York State because it's not a condition, but certainly just improving quality of life. We know that the antidepressant effects, are real, and I think anybody would admit that, if you have a diagnosis of terminal cancer, depression probably go right along with that. And so that's one of the other reasons why people seek it out. And then the other reason with cancer is that some people want it for the chemotherapeutic effects that it may have. And, that's something that takes a lot of education. And I certainly, don't encourage anybody. And I actually discourage people from not going through their typical chemotherapy regimens and substituting with cannabis, because we just don't have enough data on that yet. And but certainly as an adjunctive therapy, with the potential chemotherapeutic effects that THC and all the other cannabinoids have. So cancer is one of them. And within cancer, as I mentioned, there's several different categories. Chronic pain is huge. We've tracked our patients now for several years now, and our understanding is, we have with our patients is that, if you're coming here to see us to get certified for medical cannabis, the the idea is for not just to add another medication to your regimen, but to say, what are our goals here? And my goals are to, at least minimize or reduce the opioid consumption, if not get rid of it altogether. And for pain, it's been extremely beneficial, especially now with the big push to get everybody off of opioids. It's been a great transition, and we've had great success doing that. Other conditions that we see people for, me being a GI specialist, we've seen great results with patients with a variety of GI conditions, certainly inflammatory bowel disease, which is, patients who suffer from chronic abdominal pain, and we know the beneficial effects of that. We know that it's an inflammatory condition, and THC and the other cannabinoids are very powerful anti-inflammatories and antioxidants, so they're getting great results from it in that capacity. But the other thing we do know is that it affects GI motility and GI secretions. So for patients who are suffering from significant diarrhea conditions, such as inflammatory bowel disease, Crohn's disease or ulcerative colitis, but also just irritable bowel syndrome, we've had great success. And, in New York State, we've had to kind of lump irritable bowel syndrome into chronic pain syndrome. So we've been able, at first, most people don't consider irritable bowel syndrome a chronic pain condition, but if you talk to somebody who has irritable bowel syndrome, they'll say it can be pretty darn painful. And, you couple that with how it affects their quality of life and always having to know where a bathroom is. And that's one of the benefits that we know is that it does control GI motility, slows GI motility, also slows down GI secretions, all of which contribute to diarrhea and abdominal pain and things of that nature. So, those are some of the bigger conditions that we see people for. Of course, we have the patients who seek us out for seizure disorders, Parkinson's disease, Huntington's disease, some of these other I guess more obscure conditions that in New York State we can certify patients for.
Interesting. It's so interesting to hear because I'm out in California where it's completely legal. And I'm sure, and beforehand, I don't know if there were certain conditions you could and couldn't, but I like how you have a very specific, okay, these are what we can qualify for. Because people listening, they may, if they're having any thoughts like, oh, is this really a legitimate thing? Well, the state of New York has certified that it is a legitimate thing for these certain conditions, which I definitely appreciate.
Yeah, it's and clearly they definitely have to extend their ailments that they allow certification for. But at the same time, once they included chronic pain, well, chronic pain is not just somebody taking opioids and not just somebody, people, for example, who have chronic migraine headaches. All right, they have, I consider that chronic pain. I have not, done it yet, but I certainly know there's several doctors that say, well, severe depression is a form of chronic pain. It depends how you define chronic pain, right? And so, fortunately in New York State, there's a little bit of leeway in that. And, but usually we can provide, fit them into a category of some sorts. But
I appreciate that. I like that. I like the creativity because as we well know, like you said, depression often comes with chronic pain as a side effect.
Right.
And it spirals one into the other. It's kind of a downward spiral. So if you can at least treat the chronic pain, and like you said before, THC has those effects on depression as well, you're kind of hitting it from both angles, which I'm sure is very beneficial. Right.
And if you ever see the commercials, for the conventional, some of the pharmaceuticals, I remember one commercial that said, where does depression hurt? Everywhere, right? Yes. So now we're starting to really think heavily about saying, should we be considering depression as a form of chronic pain? If that's what it requires to get patients the help they need, then I'm all for it.
I love it. Can you talk a little bit about, you said routes of administration, and that we're talking about, okay, are you going to inhale it? Are you going to eat it? What's the discussion you have there?
Well, a lot of it depends upon, what condition it is and what their comfort level is with utilizing some of these products. For people who have chronic pain, for example, a lot of times, if you're looking at, well, what's the difference between taking an edible product, in New York State, we have them in the form of a pill form or oil as a tincture form or as a vaporized form. most people, if you're having pain, they don't want to wait 2 hours for relief, which we know that the oral compounds can take that long. The tinctures, a little bit shorter than that, 20 to 30 minutes, whereas a vaporized form is very quick. The advantage is that, so people with chronic pain, there's two ways to, we typically attack it with multiple routes of administration. So we know that, for example, an oral product will, give anywhere from 6 to 12 hours of relief, but can take up to 2 hours to start working. So a lot of people with chronic pain, particularly if we're trying to get them off opioids, I will put them on an orally consumed product as kind of to give them that baseline. And then throughout the day, if they're having spikes in their pain, then at that point in time, we'll have them use a vaporized form versus, or a tincture form. The other thing that we, have to be, mindful of too is absorption and bioavailability of all these products and how the diseases affect that, but also how our body processes these. We know that when you consume THC, it goes through the liver first, and it goes through this what we call the first pass metabolism. And THC, a large portion of it, is immediately converted to something called 11-hydroxy-THC. And 11-hydroxy-THC is a much smaller molecule than THC, so it crosses the blood-brain barrier much more readily, and therefore it's much more potent. So that's why, some people, particularly in the elderly people or people that may be very sensitive to THC, we have to be very careful about starting them on an oral product because, if I've had a lot of people come to me and say, I don't want to do a pill because I had a bad experience once with a pot brownie I ate that my friend gave me. And I say, well, first of all, I don't know if that's just because they put a lot of marijuana in that brownie. But it could be the fact that, some people are very sensitive to 11-hydroxy-THC. The other thing, of course, to take into account is, if people have GI conditions and they're having diarrhea or they have inflammation of their gut, well, their gut absorption may be significantly impaired. So, they may not get the same, benefits. So, there's so many different considerations with, when it comes to routes of administration that it tends to be one of the larger topics that we spend time discussing because there's lots of misconceptions about, well, am I inhaling? Am I smoking? Am I going to cause a lung injury by vaporizing the product? And, so it's one of the, probably most overlooked topics, but it's such an important, topic, the routes of administration. And, we're seeing more and more options out there for routes of administration. And, it's all going to come down to, I always tell people cannabis medicine is a very personal experience. And we know that because our bodies are all genetically very different. And we all have our unique cannabinoid receptors, and we all have genetic polymorphisms, which means there's differences in how my cannabinoid receptors may be compared to your cannabinoid receptors and how you're going to respond. And, everybody thinks that, that it's going to be an automatic, it's going to cure everything. And, when people don't have good results from it initially, then it's a matter of stepping back and talking to them and saying, well, we have to look at this. It may be the route of administration. It may be the cannabinoid content. It could be, some other medications you're on that are interacting with cannabis. So, again, it's it's complex, and it's a very personal experience for patients, and it's unique with every individual.
And are there any conditions that a person could have that would be contraindications to using certain routes of administration?
I can't say there would necessarily be any major contraindications, so if you look at vaporizing, for example, I'm kind of lumping any inhalational form into the vaporizing, category. One of the biggest concerns people have is, well, is it going to cause lung cancer? And, right now the answer is, right now we don't have any, evidence that, there's increased rates of lung cancer. And in fact, some of the larger studies that have looked at patients who've taken, have been smoking marijuana their whole life have not had increased risks of cancer, from it. And there's probably lots of reasons for that. One of the proposed theories is that, well, we know that, cancer is caused by inflammation and carcinogens in our immune system and all this type of stuff. And one of the benefits of cannabinoids is their ability to enhance our immune system, to, have anti-cancer properties, to have anti-inflammatory properties. So now, having said that, some people don't have the ability, particularly, some elderly people who feel very uncomfortable inhaling anything, or they may just not have the lung capacity to be able to take a big inhalation. The other thing that, we have to be somewhat mindful of is that people who have COPD, or any sort of reactive airway disease, asthma, COPD, there is the chance that it can trigger some attacks of this. So, when we're talking about a vaporized form, the first thing I talk to patients about is I make sure that, they can actually take a nice, big, deep inhalation, and that they don't have reactive airway disease. But even if they do have reactive airway disease, I don't tell them, that it's a contraindication. I say that you just have to be mindful of it. The other thing, when it comes to, contraindications from a disease standpoint, the only other thing is how the gut works. If you're taking a product that is being absorbed through the GI tract, if they've got short gut syndrome, or they have inflammation of their gut, we don't want to see them fail therapy because the product's not being absorbed properly and they're just flushing it down the toilet. So, those are some considerations. But, as far as absolute contraindications go, the good news, there's not a whole lot of them. The one thing that we do know we have to be careful about is people with liver disease. The cannabinoids are metabolized in the liver just like any other medications are, through the cytochrome P450 enzymes, which are responsible for a lot of our detox. And, so there can be some, if you have impaired liver function, well, you may have some adverse effects from cannabis therapy.
That brings up a question I hadn't thought of before, but are there any medical, actual pharmaceutical interactions that make it so that somebody, if they're on a certain medication, should not be using THC?
The short answer is no. However, what we do have to be careful with certain medications, and we know that the cannabinoids in some cases can accelerate some of these enzymes in the liver, so it can actually cause us to break down and metabolize some of our other medications that we're using, where some of the enzymes in the liver, the cannabinoids actually slow down those enzymes which metabolize the drug. So what we need to be particularly mindful of is that if people are on medications where we know if that medication either gets too high or too low, can have serious side effects. Now, if you're looking at a medication that's being, say, used to treat, your cholesterol, well, probably not as important if if your cholesterol levels go up or down, as opposed to if you're on a blood thinner, for example, where if you take a medication that interferes with our enzymes that metabolize that, well, clearly if it's it can cause accumulation of that blood thinner, which could make you more prone to bleeding, or it could actually enhance the metabolism of that. So now people aren't clotting; they're clotting too much. So that's where we have to be cautious of. And the same thing with seizure medications, for example. We know that a lot of these seizure medications, if it's being metabolized too quickly, they're not going to have enough of the drug in their body, and so they're going to be more prone to having breakthrough seizures, or may. Now, again, the cannabis may offset that, but again, we have to be careful of that. And the other thing we have to be careful of is that we know that excess of some of these anti-seizure medications can lead to significant toxicity. Dilantin, for example, one of the major medications that is used for seizure disorders, has to be measured regularly, because if Dilantin levels are too high or too low, it can be associated with certain toxicity within the body. So when it comes to medications, the two things that, I think it's very important to be mindful of are people who are on blood thinners, any sort of heart medications, any sort of seizure medications, because of the potential for it to alter that drug concentration within the bloodstream. Not to say they can't use it, but fortunately, most of these medications we can monitor through blood levels, which is what I typically do in my practice. If somebody's on a seizure medication, or blood thinning medication, I'll coordinate that care even oftentimes with their doctor who prescribed them that medication to say, listen, we're starting them out on this therapy. We know that there's a potential for it to interact, although fortunately, very rarely, there's very few case reports of it actually, having interactions with these medications. But we certainly don't want to have any negative outcomes and have somebody die of a stroke or have a bleed because cannabis was affecting how that medication was being metabolized. So, in those cases, it's like I said, it's a coordinated effort, between myself, the patient, and the physician who is treating that other condition and prescribing that medication. But fortunately, overall, it's extremely safe.
I love that. That's very helpful because that is a small set of the population that's on those things. So like you said, for those of you who are on one of those, get somebody to help you monitor them. But for most everybody else, the rest of your medications are probably, like you said, if you have a little bit too much or a little bit too little omeprazole for your acid reflux, not as big a deal as the others.
Right. Precisely.
Let's talk a little bit about how you advise people on dosage.
So, there's the thing about that's really unique and I think very beneficial about cannabinoids is the fact that there's a bell-shaped curve when it comes to dosing, meaning that doses that are too low or doses that are too high tend to be non-therapeutic. And there's a sweet spot, which is another thing that sets it apart from opiates, for example, where people just find that they have to keep escalating their regimen, where cannabis is very different than that. Cannabis, and we'll have people that say, well, I was getting really good results, so I started to increase the dose of it, and then all of a sudden I started to not receive the benefits of it. And we know that that's been shown over and over again. So I'm a big proponent of the start low and go slow idea. And so when we do that, I start patients out very slow. I mean, I'm talking anywhere from 1 to 5 milligrams of THC to start, for the cannabis naive individual, where, those who are not cannabis naive, which, realistically, even in New York State where it's, still illegal, I have several patients come into me that say, I smoke regularly from where you get it from my friends or whoever they're getting it from. And they, a lot of times they'll come in and tell me, I take these gummy bears that I got from out in Colorado that are 10 milligrams a piece, and they work great for me. So that's extremely beneficial because I know already that they're, how they're going to respond to it. But for individuals who are naive to it, and particularly the elderly, when it comes to THC and wanting to avoid the risk of falls and confusion and any sort of mental status changes, we start very low. I start very low, like I said, between 1 to 5 milligrams per dose starting out with THC, and then we can always ramp it up, from there. And some of the side effects that people get from THC, we also see that if you start low and go slow, and slowly increase it, those side effects tend to go away, or at least the perceived side effects go away, meaning they get used to it. So the dizziness, the dry mouth, the fatigue, a lot of these things that people will initially experience, we know it tends to improve over time through continued use.
And I'm glad you brought that up, because with the side effects, I was imagining, we were talking about crossing the blood-brain barrier. At some point, at some of these higher doses people may need for their symptoms, do they start experiencing that high that is generally associated with marijuana?
They do. And then it just comes down to, well, do they mind that feeling or not? And, can they function? Can they go to work? Things of that nature. Now, of course, we're not in any position to be able to tell people they should be driving and operate heavy machinery and stuff when they're using THC. And of course, so that's going to have implications if they have jobs. So, but the one thing, and again, the one thing that, I utilize quite frequently in patients who say, I don't like the fact that the THC gets me high, but boy, it's doing great for my pain. It's doing great for my Crohn's disease. Is there anything I can do? And the answer is yes. One thing that we do in these cases is we increase the amount of CBD, because CBD has actually been shown to offset or mitigate some of these unwanted side effects, but most importantly, it does that while not interfering with the therapeutic effects. So, this is really, I think it speaks to the point that this is a learning process because it's very unique and individual for each patient. And that's why it's important for people considering THC therapy to really be involved with somebody who's experienced with it, and can provide good guidance.
Yeah, speaking of that, I'm getting here that I know you have a colorectal surgical practice, but are you seeing patients in a consultation form outside of the practice, the ones that you're helping with THC with these other conditions that are not colorectal?
Yes. Now they're still all within my practice. They come. It's just a separate visit for separate indications. I'll see patients for newly diagnosed colon cancer. In the next room, I will see somebody who's interested in using medical marijuana for chronic pain or whatever the case may be. So it's kind of mixed between. I also have some other providers in our practice as well who see our patients as well for medical cannabis.
Very cool. And tell us about the book that you wrote in case anybody would like to learn more.
So I wrote a book called Surgeon's Perspective on the Science and Truth of Cannabis. And this what really started out as kind of an FAQ for my patients. Patients come in and they say, what is cannabis? How does it work? What is this endocannabinoid system that I'm hearing about? So I initially started out just making a very simplified, a pamphlet, if you will. But then I just kept adding, well, what's the science behind that? And next thing you know, before you knew it, I had a little more of I wouldn't call it a textbook, but certainly something that's a little more robust than a simple, handout. And, and I really also wanted to state facts, in this book. And also the other reason I did it is because it's been a great resource for my referring providers, for them to say, is this patient a candidate? And if for it, and if so, they're interested in learning about it as well. And the nice thing about it is I don't sugarcoat anything. I don't, I stick to the science, and I tell people what we know and what we don't know. And unfortunately, right now, a lot of that comes from preclinical data, and which for the audience, understanding the difference between preclinical and clinical data is preclinical data is not done on humans. It's done on animals and in the lab and stuff. And we use that as translational evidence in humans in a lot of our studies. But I'm very clear, in my book about, that, yes, this has been shown to have anti-cancer properties in animal models for colorectal cancer, for example. We cannot make claims that the same is true in humans. But I certainly go through that in the book and talk about, where the real science is, what do we know, and also what do we not know? And, where are these knowledge gaps, and what do we need to really figure out for the future?
Thank you so much for everything that you've brought today. This has been so informative. I like a lot of the irritable bowel and the IBD conditions I had not heard of, how specifically cannabis worked on those. So very enlightening for me, and I'm sure everybody else out there. If you could tell people how they can find you.
Sure. So I have a CBD company at reservemdhealth.com. So www.reservemdhealth.com. I can be found there, or I can be found through Adirondack Gastrointestinal and Colorectal Surgery, which is my surgical practice.
And I'm guessing your book is on Amazon.
It is, and it's also on our website as well.
Okay. Fantastic. Thank you so much for joining us today, Dr. Abodeely.
My pleasure. Thanks for having me, Lynn Marie.
All right. Until next time, everyone.